हाँ सामने। अच्छा।
Hope now screen sharing is visible to all.
Yeah,
Can you
it's
share the
visible.
screen share?
Yeah, it's
Yeah, I,
visible.
I can see it, yes.
Okay.
And you will change the slide.
I will change
You
the
will change
slide.
the slides
Raghavan sir,
for me.
you can check your the screen for the talking. You can change the slide in your screen
Okay.
also. Okay.
Oh, I
And
can also change. Okay,
when you
fine.
ask me to change the screen, I will change the screen.
Oh, okay. No, if I can change it, that will be best as it at all.
No, you can't change it. I have to change
Oh,
the
okay. Yeah.
screen, but for your
Okay.
reference, you can open that file in your computer also in your system.
Oh, okay. Right. No problem.
Now I will request the President UPAOP to start the session. Dr. DM.
Just a minute, ma'am. Now, I think it's okay now.
Yeah, finally.
Thanks, ma'am. A very good morning, respected seniors and dear colleagues. I, Dr. Dheeraj Mohan Gupta, President UPAOP 2025, along with my secretary, Dr. DK Bhagwani, and other office bearer, welcome you all on the behalf of UPAOP to this August gathering. I feel blessed and honored that UPAOP taking the leaps and bounds in the field of academics now, not only in the state, but across the nation. It's ever for the first time, the E-classes, particularly the pediatric cardiology, is going to head under the banner of the UPAOP. Today we have launching session. Really, we have crossed the boundaries of UP state. Today we have bumper approximately 115 delegates on the board, along with the learned faculties and the seniors and other dear colleagues. We have crossed the boundaries because we have registration not from the UP state, but from Vishakhapatnam, that is Andhra Pradesh, Raipur, Chhattisgarh, Chandigarh, Shimla, Himachal Pradesh, Karnataka, and many more states. The faculties have registered here. We are feeling blessed that with the blessings of our seniors and our dear colleagues, we have achieved this one. Now we as a UP, now we are marching forward for a wish guru in academics, respecting others and holding others' hand in hand. We have launched our UPAOP state presidential action plans this year also under my presidency. DAD module, that is diagnostic approach to infectious disease. It's the first stage for doing so. Last year, we have launched this Swadeshi module, which was made by the faculties of the state, but it is for all, irrespective of the caste, creed, religion, and the region. And that was the fever module, which was launched by none other than Dr. Vivek Saxena, immediate past president. Today's academic program is the result of the brainchild of Dr. Manish Tomar ma'am, who along with Dr. Roli Srivastava and Dr. Abhinav Agrawal and many more, whose names are behind the curtain, but each one has put their 200% effort to bring this e-learning classes in front of you. It is the teamwork which has given us the vast platform to share our views. Today's session will be taken by none other than who is the we can say who is the father in the field of pediatric cardiology, and he is Dr. Raghavan Subramaniam sir from Chennai, who to whom we will listen and enrich ourselves with the newer insights. Today's session will be chaired by none other than our batchmate, Dr. S.N. Singh, who is the professor and head of Department of Pediatrics, KGMU, and Dr. Saad from Jawaharlal Medical College, KMU, Aligarh. Once again, I thank all the persons on the board who are present here as a family to exchange our views with each other in a coordinated and in a coordinated way. We will exchange our views to each other. I think I should not take much of the time because today's session is more important rather than putting our views. But it was my views as a president. I feel pleased once again. And thanks, ma'am, for giving the opportunity along with my office bearers to bringing this e-classes in front of all the people across the nation. Thanks once again, all the learned faculties. Thank
Thank you.
you.
Thank you, Dr. Gupta, and very warm welcome to this e-learning program, Basics of Cardiology for the Pediatrician, and nobody can be better than Sir to start this presentation. I thank you, Dr. Bhagwani, Dr. Vinay Saxena, Sir, Dr. Ruchira, Dr. Amit Rastogi, all the office bearer, and a small team of pediatric cardiologists in the UP. We all have joined hand to just start to reach the remotest area of the medical college in UP where we can connect at least by e-learning. So just to give push to the pediatric cardiology in Uttar Pradesh, this is our focus. And thank you always. The chairperson for this session is Dr. S.N. Singh from KGMC and Dr. Saad. Now, without wasting time, I request both of them to introduce Sir and just we go ahead with the first lecture, that is the history taking in child with suspected cardiac disease. Over to you, Dr. S.N. Singh and Dr.
Yeah.
Saad.
Yeah. Good morning, Dr. Munes. Am I audible?
You are audible.
Yeah. So, very good morning to all of you, and congratulations to the UP Academy of Pediatrics and the cardiology team who have taken a lot of effort in starting this very important e-learning platform. It's very important for, especially for PGs who can learn and who can inspire even. So congratulations for starting this such type of programs. And today is the first day of this lecture series, and the topic is art of history taking in a child with heart disease. So speaker is Dr. Raghavan Subramaniam sir. So he is a very senior person in the field of cardiology with more than 46 years of experience. He graduated and post-graduated from Gwalior Medical College. He did his TM cardiology from AIIMS New Delhi in long back 1980. He has received several fellowships. He works in various positions and capacity. He worked as a senior registrar in New Zealand, lecturer in Muscat, and at various positions in India. So currently, sir is a senior consultant cardiologist at SIMS Hospital, Chennai, and he will be talking on art of history taking. Sir, I think you will be the best person to realize the people that how important is the history taking. So welcome to you, sir, and over to you, sir.
Thank you, Dr. Singh, for those kind words. And good morning, everybody. Respected Chairman, Dr. Manish Tomar, Dr. Gupta, President of UP Academy of Pediatrics, and all your esteemed colleagues in the pediatric and cardiology faculties of Uttar Pradesh. I'm very impressed by your activities. You are doing a great work in spreading the education among young doctors to not only UP, to the entire country. Being an online activity, everybody in the country can benefit from this. It's a very, very important program of e-learning, taking the advantage of net connectivity, and with people can attend in leisure without ignoring their duties, and definitely will take them a long step in understanding the subject and practicing the subject in a very ethical and efficient manner. Congratulations. I'm humbled and honored that you have called me to give this lecture. And although it's a very, very basic topic that I'm going to talk, it's one of the most vital parts of clinical medicine. It's the first step in any evaluation of a patient. This talk is entitled Child with Heart Disease. But if you really think, history is the first step in medicine, whatever be the specialty, with pediatrics or adult medicine or any specialty. I'll of course be aiming my talk towards my younger colleagues in pediatrics, who I hope will take up pediatric cardiology as a career. But the points I'm going to make about history taking will probably apply to equally to all the specialties and all subjects. and therefore should be useful to every pediatrician. So without wasting further time, let me go on to the actual subject. Now history taking is extremely important. The first step in the evaluation in your contact with the patient. And it is also the time to break the patient's anxiety barrier and take him or her into your confidence. Now, history provides the diagnosis in almost more than 50% of the cases by itself, even without going on to for further investigations. Therefore, we need a very good history. The aim of a good history is to get a bird's eye view of the patient's health. You want to find out what system is likely to be affected. Where do we start investigating? You can't do all the investigation and all the tests and all the physical sign in every patient. Then you will be spending the rest of the year on one patient. Now, the idea is to take a good history, get a bird's eye view, and then you are able to perform a focused physical examination for clues to the diagnosis. History helps you to formulate a clinical diagnosis in many cases, along either by itself or along with investigations. It improves your clinical efficiency, it improves the patient care, and by itself, the very fact that you're talking to the patient for a given time at the beginning enhances its reassuring value. By itself, it is a great therapeutic tool. At the same time, it also gives you a unique opportunity to know the patient. What is his level of comprehension? What is his level of understanding the problem? And how are you going to counsel or prescribe treatment? And therefore, you need a patient's understand his level of intelligence, level of education, level of comprehension, and then plan your advice accordingly. Next slide, please. Next slide. Yes. Now, once you take the history, analysis and interpretation is very, very important. That's the next step. Now, history provides an extremely useful way of clarifying your own thought about the patient. You start with a blank slide, blank board. You don't know anything about the patient. So when you ask his complaints and history, you have some idea of his problem. It clarifies your own thought. It converts a random search of the diagnosis. The whole textbook of pediatrics is in front of you when you open the evaluation of a patient. But then it turns that random search into a systematic process. You know where to begin, where to step forward at the next step, and then where to make conclusion. It also allows you to share the patient data for discussion. Now, for example, well, in teaching, we always share these things with you, but you also share this data with your colleagues, with your senior, with your colleague when you want a second opinion, and so on. So it's enabled to share the patient data. And always remember, history is not the same in everybody. The complaints may be the same, but history has to be tailored and refined according to the patient and according to the expected disease. Next slide, please. Next slide. And always remember, can you go back for a minute, that last line? Yeah. And always remember, history is also a great way of assessing your own clinical competence. This is used by your senior when assessing you for your efficiency. It's used by the examiner from the examination, and it's also used by your own colleagues to evaluate you when they deal with you. Therefore, your history should be great. It should be well taken, well summarized, and well concluded. Thank you. Next slide. Now, history is the first step in evaluation, and all textbooks of pediatrics or medicine teach you that after history, you examine the patient, and once you examine the patient, you formulate a clinical impression, and then do some tests, and then that's where you arrive at the final diagnosis. That is the pathway along which you're expected to print. This is what you're taught in the textbook and by me. But this figure is little misleading. It suggests that it is a one-way road, that you start at the history and go down to the examination, then diagnosis, and then test and final. It gives you a wrong impression. That's not the way we work in real life. In real life, we work with all of these modules together. Next slide, please. See, nothing prevents you from going from history to examination and then coming back to history, because when you take a history, you get some clues. You go to examination, you get some more clues. And then once you have taken a history, and then you may want to clarify. That's very important. Now, so when you take a history, no, wait, please wait on the slide, the same slide, yeah. When you take the history, so uh, you can, I'm hearing some crosstalk, okay. Now, when you take a history, patient complains of breathlessness, and you examine the patient, and you find that he has signs of aortic stenosis. So, would you like to go back and ask some questions? Yes, you would like to go back and ask him whether he has any pain suggestive of angina. Maybe you didn't ask that the first time. You may want to ask him whether he feels giddy on exertion. When he walks up the step, does he feel giddy? Which he forgot to mention when you took the history. So it's all a two-way step. History and examination, you can go back and forth. From examination and clinical diagnosis, you can back and forth. You can go back, you do read the biochemical test, and you see a little marginal value of some problem. He has a slightly elevated SGPT, slightly elevated bilirubin, and he did complain of some right upper abdominal pain. So you now all these suggest some hepatic congestion and possible right heart failure. Now, first time you thought the jugular venous pressure was normal, but then you may want to go back and reevaluate the jugular vein. Those that be sure that the jugular venous pressure, because everything else is suggesting right heart failure. You may want to recheck it. So it's all a to and fro process, and you take advantage of the entire information available. It's called it's entire history, examination, test, and for initial diagnosis, all put together to give you a final diagnosis. So you go back and forth. It's not a one-way street. Next slide, please. Okay. Now the history has to be different in different patients. For example, you may have a patient in a different settings, and therefore the history will vary accordingly. A patient who is first time coming to a hospital is a non-emergency stable patient. He's got a complaint going on for maybe 2 years. Now that's a very elective history, and therefore you probably have to go through a comprehensive history taking. For example, you have to cover all the complaints, you have to cover all the systems, you have to ask a number of negative for possibility of negative questions. Okay. On the other hand, if you are working in the emergency room and the patient presents at midnight in the emergency room, you have an acute problem. Doesn't come for a 3-year-old problem. He comes for that. I am having a chest pain from last night. He's having acute breathlessness in 3 days. So it's an acute problem, new problem. Therefore, your history has to be problem focused or targeted. And this is a history you will be taking in the emergency situation. Of course, when the patient has been stabilized, you will probably go back and take a comprehensive history in that patient next day morning. Of course, there are patients who are registered in a hospital and keep coming back for long-term follow-up and occasional aggravation of heart failure. And therefore, you have a basic history already on record in the computer. Nowadays, it's all electronic health record. And for ongoing care, you just ask them a focused history, which depends on the expansion of the current problem. So you have a comprehensive history, you have an emergency history, and you have a ongoing history. It's all a combination of these three, which gives you the total history for problem identification, description, and management. Now, any textbook or any article on medical history teach the method of history taking in this heading, and you are familiar with that. I don't really have to go into details of this. All of you have been studying from third year MBBS, all these things. You start with the presenting complaint, just all the symptoms. You prepare a detailed history of the present complaints, then go into the past medical history of birth, vaccination, medications, developmental history, socioeconomic history, and family history. And next slide, please. And all books and all articles on medical history taking. Next slide, please. Gives you detailed list of divide. No, please stay on the slide. Don't change. Don't change. No, back. No, back. One more slide. Okay. Every system is covered in the form of detailed tables and wait, please wait. Don't change. Please don't change. Go back. Yeah. Now, for example, the first box above gives you all the symptoms and in cardiovascular symptom or a patient who comes with respiratory complaint, dyspnea and chest pain and all that. And the second box relates to general constitutional symptom, which of course is taken in every patient. But a patient who comes with predominantly GI symptoms, there are tons of questions to be asked. Now, you can't ask every question in every patient, please remember. At the end of the focused history taking, you also have to concentrate on what is called a review of systems, ROS, or systemic history, where every system is covered and you have to go through a list of symptoms, and this list can be unending with them. So it is up to you, and time is not unlimited. Remember, whether it's exam or whether it's the OPD or whether you are in the admission ward, your time is not unlimited. You may have 6 admissions in a day and you cannot spend more than half an hour to 45 minutes on a patient. So you have to be smart. You have to identify likely questions which are important, dismiss some questions which are not likely to be important, and that is where your skill and intelligence comes in. That is where you are assessed also. So that you have the option of giving no history of wedding, no history of this, no history of that, no history of that, no history of this, no history of that. You can keep going for next half an hour, but that's boring, non-informative, and often viewed very poorly in the examination. Your colleagues will not be impressed by that history. Now, it's very important to, when you give negative complaints, you have to be very, very focused. If you have a cardiac patient, you know exactly what negative complaint you should say. If he had dyspnea, you should say whether there's paroxysmal nocturnal dyspnea, whether he has orthopnea, that is dyspnea related to posture, whether this dyspnea was on exertion, and what degree of exertion that was produced the symptoms, and so on. Whether any medication has relieved it. So very specific. If he didn't have an orthopnea in a patient who has dyspnea on exertion, that's a very important negative point. Now, on the other hand, saying all the negative complaints mentioned in this list would put people to sleep. So that's not what we want in a systemic history. You have to be selective. Next slide, please. And next, okay. So history has to be, no, please stay on that slide. Yeah, the previous one. Yeah, it has to be comprehensive and focused at the same time. Now that those are two contradictory words I'm taking. It has to be comprehensive. At the same time, you should be able to focus on what is relevant to the patient. Constitutional symptoms like body aches, fever, loss of appetite, loss of weight, these are common to all diseases, and therefore they would be present. The important point I would keep on repeating in this talk is every question that you ask should be relevant. Should be relevant. Every point that you present to another audience should be relevant to the patient. Next slide, please. Next slide. Yeah, this is a very important picture. If you look carefully, it conveys a number of messages about history taking. The first, the foremost, it tells you what's the ideal position for the doctor and the patient to be taking a history. Not that the doctor is sitting very close to the patient. Now, the people who are experts at media and communication, they say that you shouldn't have a table or a chair or some furniture between you and the patient. That really gives a sense of closeness, a sense of confidence. This young lady doctor has a very pleasant smile on her face. It's very reassuring. Look at the child, how anxious she is. She's worried. What is this terrible lady going to do to her? She's very worried. She's staring at the doctor. And the doctor, in turn, has a very reassuring smile. She doesn't even look at the child because she knows that the child is scared of her. She's looking at the mother and gives a broad smile. Now, that reassures the child that the mother is friendly with the doctor, therefore, she cannot be harmful. Now, she has a pad and a pen in her hand, but when she is looking or talking to the patient, she's not writing. That patient gets that impression that the doctor is giving her full attention. Now, on the other hand, when you talk to the patient, you keep on writing in the paper, the patient doesn't feel comfortable. She says that the doctor is giving only 50% of the attention. The mother is not looking so worried. She's been reassured by the patient's doctor's appearance, and that confidence will be conveyed to the child. They have a body language, the child will be reassured. And periodically, the patient doctor may even touch the child after some time, and therefore that loosens up the tension and makes history taking and subsequent examination very comfortable. That's important. All these are small points. Nobody teaches these in the textbook. And these are small points and these are the points you should observe. You should observe your senior doctors, how they deal with the patient, how your consultant takes history in the clinic, how your consultant touches the patient in the ward, how he pats the child, reassuring. So child becomes relaxed. He allows the doctor to palpate. He allows the doctor to auscultate and so on. This is a very, very important slide as far as I'm concerned. These techniques cannot be taught to you. You have to observe, you have to learn, and you have to practice. Okay? Now, this is the first important thing. And then, of course, you start with some reassuring question. Don't jump into it, say, tell me, do you have chest pain? Now, that's a very difficult question to answer. Who doesn't have chest pain? Everybody has chest pain. You have to ask with gentle questions and what brings you to the hospital? How can I help you? Next slide, next, press the next one, please. Yeah, what brings you here today? Ask some gentle questions. How can I help you? You can ask a couple of questions about their well-being and what they do, which school is she studying. So ask some general questions, put her at ease. Now there are some. These are all common points, which we all make use of all these tips in our general social relationship with other people. So we have to use these in history taking to a greater extent. Allow the patient to talk in their own words. Don't interrupt for the first few minutes. Encourage them and just observe their verbal and non-verbal body language. Try not to interrupt. Hear what they say. But they are not doctors. They haven't studied the textbook of medicine. They don't know what is important and what is not important. They will tell you a mass of information, some of which is important, some of which is not important. So you have to guide them. You have to ask, clarify, okay, which came first, which is bothering you more, and how serious is it, and so on. If there's any gap in the event history, you lead them to those and clarify them. Some areas may need more clarification. He did mention breathlessness, but you're not sure how severe it is. Which activity is harmed or inhibited by the symptom? And therefore, you have to ask questions and repeatedly to grade and get more detail. Finally, summarize the history and just talk it out. Talk it out in front of the patient and invite the patient to comment. Is that right? Is that what you're suffering from? Is that what you want to tell me? And the patient may say, no, doctor, I didn't mean that. I didn't mean that I fell down unconscious. I only meant that I felt a little giddy and I sat down. Those are the little clarity. Loss of consciousness is different from felt giddy and sitting down. Okay, they're very important. These are the things which you have to clarify. Next slide, please. There are more histories. I already mentioned giving them your undivided attention. That is very important to get their confidence. Gently guide them to relevant areas. They often drift. I ate watermelon one day and that caused me abdominal pain. And then I went to a doctor, and the doctor was a MD pediatric, but he works in a medical college far away from my home. Now, from the patient's point of view, he doesn't know that these are all irrelevant. It doesn't matter whether doctor MD or MBBS, doesn't matter where her medical college is located. You have to gently guide the patient, come back to the relevant areas without sort of making them uncomfortable. First, general questions, later on, specific questions. And note that your history has to be up to date. Now, if you took a history last week and you're presenting the case today, you can't ignore the last 1 week of history. It has to be till the day of interview or till the day of presentation. It has to be up to date. That's very important. Many students ignore this and get into trouble in the examination. No, they were seen in front of the examiner or in front of their consultant on round. You're not up to date. You don't know what happened yesterday. That's part of your history. Watch for clues. So the patient may be telling you that he has chest pain, he's unable to do this, unable to do that. But I will be telling you that I have some problem at home. I'm not able to do this work at home, but at school I'm able to do everything. That tells you there is some emotional factor at home which is not, or the other way around. In school she's not able to perform, but at home her behavior, everything is behaved. So that tells you that something is not some relationship, something is not okay at school. So you have to watch for clues, dig in between complaints and clarify, and try to find out what are the real concerns of the patient. You got it? Okay. And why did the patient come to you? What does she really expect from you? Just temporary relief of symptoms. Once your total evaluation and full diagnosis and complete cure, these are the important things to find out. Next slide, please. Next slide. Okay. Now, this is a common slide to any history taking. Any complaint, you have to ask a number of questions. And I don't have to repeat. You should already be knowing this. When did it start? How severe is it? every complaint has a grading scale. You must know that grading scale. Now, how does it affect the routine activity? And where does it start and where does it spread in the body? And what factors initiate the pain? What factors aggravate the pain? What is the quality of pain or breathlessness, whatever it is? You may have burning pain, you may have a stone-like heavy pain. Yeah, keep it on this slide, please. Don't change it. What relieves the pain? Maybe rest relieves the pain. Maybe lying down relieves the symptoms of giddiness. Maybe some medicine relieves you. So, associated symptoms. Now, if he has breathlessness, if he has profuse sweating, it has a different significance than a transient pain which doesn't have any associated symptom. If somebody has breathlessness, palpitation, and has giddiness and almost a near faint, that has a different connotation. If that symptom is very, very frequent, coming daily, coming several times a day, and going on for many, many years, that's a different set of diagnosis. If it is started only yesterday, it's an acute condition, something went wrong yesterday, maybe even an acute abdomen or something like that. And of course, there is treatment. Now, every question you ask the patient and the answer that you get has a clue to the diagnosis. Now, your job is to sort it out, filter it, and keep them. Now, I did mention that grading of symptoms is very important. Obviously, more severe the symptoms, you expect more severe the disease. But sometimes you have very severe disease, but without any symptom, very mild symptom, like aortic stenosis. Very critical aortic stenosis can exist without any much symptom, maybe very mild dyspnea and mild giddiness. On the other hand, you may have aortic stenosis with severe symptoms. Now, most curative or interventional treatment or surgical treatment in cardiology is used only for more severe symptoms because cardiac interventions and surgery have a certain amount of risk and you would like to not intervene too early, and therefore you like to wait that the symptoms are little more severe, heart failure or whatever symptom, little more severe. Very few situations we do operate in asymptomatic or mildly symptomatic patients. Therefore, we have different classifications. And this is one such classification derived from the Ross's heart failure. I'm sure pediatricians are aware of that. Your pediatric textbook gives you Ross classification of symptoms in heart failure. Most classifications divide symptoms into 4 categories. Category 1 is asymptomatic on normal routine exertion. Everybody is symptomatic when they exert more than normal. When you run an Olympic race, even the Olympic athlete is breathless. But at normal activity is asymptomatic. Second one, symptoms on mild to moderate exertion. Third one, very little activity. And the fourth one, even at rest. No, it may be the symptoms may be dyspnea, it may be the sweating, it may be discomfort, it may be palpitation, so on. And therefore, your history should read something. He had initially grade 2 symptoms, progressively increasing grade 3, and about 3 months ago was admitted in class 4. After treatment, he has returned to class 2 and is going on in follow-up. Now, I forgot to mention this. Anybody wants any questions, you're free to stop me and ask me in the middle also. I forgot to mention that in the beginning. You can ask me in middle. You can also put your question down in the chat box, and we could have go through the questions at the end of my talk. So grading of symptoms is very important to know how severe it is. It's very important to know how the progress of the patient has been till he came to you, and of course for following up the patient and to decide the need for intervention. Next slide, please. Now we have taken all these questions. You're got a jumble of data on your paper. Now the idea is to make it a story. A story means something interesting to listen, not a boring recitation of negative, 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 positive, positive, positive complaint. That's not the way we want. We want to make history means actually his or her story. A story, everybody likes stories. Even your consultant likes story when you present a patient. So it has to be a fluent, very interesting story made up of simple, short sentences, easy to understand, but accurate. Next point, press next. Yeah, next sentence. Now, whatever forum you present, you want to make a good impression. Even the patient is listening to you when you present the history. So your opening sentence is a very important line. Remember, any talk, the opening line is very important. It creates an impression, and therefore it's important the introduction. For example, If you want to present a history, it's very nice to start. Sir, good morning to you. I'm here to present the history of my patient, a pleasant young boy of 8 years, who comes to me with the history of exertional breathlessness, which developed about 3 months ago and has been recently increased in severity. No, just start something with something important. In fact, that was probably too long a sentence. You can make it shorter sentence and make it. Always start with the presenting complaint and why he came to the hospital. Patient may have 10 complaints, but the reason he came to hospital would be what troubled him more and what troubled him recently. As far as possible, your details have to be in sequential order. So that gives a sense of the disease, what came first and how it deteriorated, how it improved, so on. It has to be according to the time of occurrence. Next line, please. Okay. Again, as I said, your job is to sort out the information, relevant, not relevant, important, less important. And now, when you're presenting the history, it's not just recitation. Your interpretation becomes very important. Now, when you're finished with a group of symptoms and the description, you will be making interpretation. And I would come to that interpretation a little later. Now, highlight important negative points. If you have a cardiac patient, what are the important negative points? All the complaint that you ask of, if they are not there, become. So, patient doesn't have syncope, it is important. Patient doesn't have abdominal pain, it is important. If patient doesn't have chest pain, it is important. So, those are important negative. You should also ask negative questions in the other system depending upon your suspected disease. For example, you have mitral stenosis. You know that mitral stenosis patients are prone to pulmonary edema. So you can say acute deterioration of breathing comfort accompanied by fever and cough. Mitral stenosis can form a clot in the LA, and this clot can dislodge and embolize to the brain. So if the 18-year-old youngster with mitral stenosis, so you want to know whether he had any neurological episodes, he had any transient hemiplegia, is any transient aphasia to rule out thromboembolic episodes. So you have to have negative points, okay, at these points. Next point, please. Next, okay. Now, there is no perfect way of presentation. I'm telling you, there's no perfect way of history presentation. You have to develop your own style. You watch your consultant, watch everybody presenting, read whatever you want. But before you present, you have to do certain some preparatory work before you start talking. And you have to be quick. You don't have, again, unlimited time. It's good to always write down your findings and spend a couple of minutes thinking about them. You don't want contradictory findings. The patient class 3 before and then class 2 after. No, you have to be very sure you know what is class 1, class 2, class 3, class 4. We say mild and moderate exertion, but it's always related to patient's own exercise custom or habit. For example, the degree of activity of a 1-year-old child is different from activity of a 14-year-old teenager. It is different from activity of a person who is 20-year-old, different from a lady of congenital heart disease at the age of 40. Oh, they have, for example, a schoolboy would be running to school. He would like to play with his friend. A 14-year-old boy would ride his bicycle, play soccer. A 48-year-old lady with heart disease will not do anything. She will sit at home doing nothing and even avoid the kitchen. Give the work to other ladies to do in the house. I already mentioned negative one. Next one, please. Keep going to the last point in this slide. Yeah, next. Filter out improbable statements. So as I mentioned that the patient is not a scientific person. So you would make some very improbable statements. I had severe chest pain and I went to a doctor who gave me enema and I got better. Now it doesn't make any sense. He had chest pain, he went to a doctor who gave an enema, he got better. Now it doesn't make any sense. Now the worst thing that you can do is to repeat that in the history presentation verbatim. The examiner will sort of not like it if you say the enema relieved his chest pain. You understand what I'm talking? Therefore, always filter out improbable statements. Although the patient makes it in sincere nature, he is genuine because he doesn't know the silliness of that statement. Try to understand what the patient really wants to say. All he says is it happened on that day. Okay, correlate different findings. Now, he said 5 years ago he had an episode of severe chest pain. I could not go to school for 10 days. And now he comes with a rheumatic mitral regurgitation. Now, you should correlate the two. He had an illness for about 2 weeks. He didn't go to school. And he doesn't know what it was. And then now he's having mitral regurgitation. So you have to ask more questions whether the first episode was rheumatic carditis, rheumatic fever. So you have to correlate two things which may be related. You have to extrapolate findings. Okay, then ask questions whether he was given penicillin, whether he was advised to take rest after discharge from hospital, whether he was given long-term penicillin. You have to ask those questions. Next slide. Next. And most important, whether you are presenting to your examiner or to your consultant, please you write down for your understanding, for your clarification, but do not read the history. You should be confident and you should talk facing the examiner. Look at the examiner and talk. Periodically, you can refer to the paper, but talk should be facing the person to whom you're addressing. Similarly, when you talk to the patient, face the patient and talk. It's very important your history must be well organized. Talk in a very, very sensible manner. Do not go back and forth. Do not go from present history to past history and then come back to present history. Do not go from chest pain to dyspnea and then come back to chest pain. That creates a very, very bad taste in the mouth. Next slide, please. So there are a number of data points you have collected, and now it's time to make conclusions, because before you start presenting, you have to make conclusions. Now, there is something called summary of the history. This is, I feel that's the most important part of history presentation. Now, that is the single line which tells me as a teacher, the examiner, or your consultant, how good your history is. Now, start with a good short summary statement. Many students confuse a summary statement with repeating the whole history of present illness. Now, when I ask for a summary statement, please do not repeat the whole history of present illness. I don't want the whole of it. Now, I'll give you some examples using cardiology cases subsequently. Therefore, a good summary statement means you should summarize the history in just one or two sentences, which conveys everything that is important to know. And it should not have any unnecessary words, should not be longer than one or two sentences. But it gives me an idea of the whole history of present illness and past illness. I'll show you some examples. Now, when you try to conclude from the history, it's very, very important that you should not overdiagnose. Sometimes I have a student who presented to me, a patient who had dyspnea for 5 years, now deteriorated to class 3, then came back to class 2 on medication. He also had fever for 1 month at the onset of illness, and chest pain in the abdomen. He had loss of appetite, loss of weight, so on and so forth. Then when I asked, what does the history suggest to you? The patient will say, I think the patient has mitral stenosis with atrial fibrillation and heart failure, and I would like to rule out aortic stenosis. Now, that's a gross overdiagnosis of the patient from a history. History does not tell you the precise anatomical diagnosis. It never ever tells you the precise anatomical diagnosis. It only tells you the pathophysiology, what system is involved and what is the type of nerve. For example, if it's a cardiac disease, it tells you whether there is cardiac compensation or cardiac decompensation. It tells you broadly whether the right heart is affected first or whether the left heart is affected mostly. It tells you whether mild affection or serious affection. That is the type of information you get. It doesn't tell you it's aortic stenosis or mitral stenosis. Now, that is a mistake that many students try to do, because they want, by over-diagnosing, they are trying to impress the examiner. That is not what history has. Its limitations. It can only diagnose to a certain extent. So you should know those limits. Some examples. I'll give you some real-time histories and tell you. And this is the history of a patient. It's a long history, but this is a 4-year-old boy who came with decreased appetite, intermittent vomiting for 2 months. He also had exertional dyspnea, function class 3. That means even the mildest exertion, going to the bathroom or eating food, produce breathlessness for the last 2 months. Next slide. Press next, please. Okay. Now, when you went into the history, the appetite was decreased for 2 months, and the vomiting was non-bilious and so on, and a lot of blood disturbance, not blood stain, no bowel disturbances, never had any bowel abdominal pain. He had initially class 2, gradually going on to class 3. He never had paroxysmal nocturnal dyspnea or the orthopnea. Next slide, please. Next slide. Negative complaint, no chest pain, palpitation, pre-syncope, syncopal episode, pedal edema, although he noticed some facial puffiness at the beginning. Now, initially he said, I have no edema, but when I went to the concluding part, I felt that something was not okay. So I went back to him, asked, did you have any swelling in any part of the body? He said, no. Then I asked the mother, did you ever notice a child to be puffy in the face? Then a mother came out, yes, some days I do feel the child is puffy in the face. Now, this is what I meant by initial complaint and then clarification. He had breathlessness, but he didn't have any fever, cough, or wheeze. He didn't have abdominal pain, and so on. Okay. Now, these are the points which I would like to ask on the history. Next slide, please. Okay. Now, some more point. He had history of atopic dermatitis and mild eosinophilia. At 7 months of age, he was treated. He went through. He was started on furosemide and aldactone for the past 1 week, and he felt better. Personal history, nothing was important. Next slide. And student also presented number of points here. Parents, surgery, so on and so on, birth, NYD, normal vaginal delivery, family history, some maternal cousin died, the child had hepatic disease and so on, no history of COVID. A lot of points here, but now if somebody is asked, what is this history? How do you start? Next one. Now, this is the most important problem description or the summary of history, the first line. How do you summarize this history? This is how I would do it. The 4-year-old boy, gradual recent onset progressive exertional dyspnea. He has no orthopnea. He has poor appetite, poor weight gain, and vomiting. Symptoms have improved with diuretics. Now, this is the crux of the history. Now, there are some minor points in the past which I don't think is very important because it doesn't correlate with what he has presented. But I would keep it at the back of my mind and to visit if suppose something else comes up on examination or in physical test. So this is a summary statement I would make. If something like that from the student would be very, very welcome. Now, what does this history suggest to me? It suggests to me heart failure. Right? A child, he has exertional dyspnea, but he has no orthopnea. That would suggest that maybe the right heart is probably right heart circulation more affected than the left heart. The right heart failure would be my diagnosis. While vomiting appetite also fit in because the hepatic congestion is part of that and failure to thrive. And symptoms better with diuretic. That's what. Why can't it be respiratory illness? He never had tachypnea to begin with. He had see, dyspnea is different from tachypnea. Dyspnea is difficulty in breathing, not just fast breathing. He didn't give any history of fever. He didn't produce any sputum. He never had hemoptysis. All this is I have that information in my mind, but I don't have to say that in the summary of the history. So I would say it's a right heart failure. Now, I wouldn't say it's right heart failure due to tricuspid regurgitation or mitral regurgitation or pulmonary hypertension. I don't have that information. You got it? This is history suggestive of right heart failure. That's all I have to know. I don't have any clue due to the cause. But one second, please stay on the previous slide. I only know that this slide tells me that it is heart failure. Next slide, please. Yeah. Now, heart failure onset in different age different diagnosis. A neonatal heart present with heart failure, could mean that it has a neonatal tachycardia or prenatal tachycardia. It could be neonatal tricuspid incompetence, could be neonatal pulmonary hypertension. It could be a complex heart disease like transposition or single ventricle or a neonatal coarctation. If it occurs somewhere between 3 to 6 months, I know that likely to be a left to right shunt lesion because the PVR, which is high in the neonatal phase, falls to lower levels around 3 months. And heart failure setting on in the 3 to 6 month period and aggravating towards the second part of infancy suggests to me a large left to right shunt. Of course, cardiomyopathy, myocarditis, tachyarrhythmias can also produce heart failure, but shunts are the predominant thing. Now, if you have a heart failure coming between 1 and 10 years, can you have rheumatic heart disease? Unlikely. Rheumatic carditis, acute fever can happen. But established rheumatic valvular heart disease, unlikely so as a young patient. Can happen occasionally, but it's unlikely. Of course, cardiomyopathy and congenital heart disease causing heart failure in the later age. If you have more than 10 years, you think of different conditions. VSD, aortic incompetence may set in the second decade of life. You could have rheumatic valvular heart disease in the second decade of life, and you could have viral myocarditis, and you can have cardiomyopathy. So on. No, the importance of the history tells you that you can put this patient in one of these boxes and make a list of probable diagnoses and start working towards that in your history taking. Next slide, please. Next slide. Yeah, suppose you know that a patient had a VSD in infancy. Now he has come to you at the age of 24 years. So you must know what are all the events that happen to a VSD on follow-up. A VSD can undergo spontaneous closure, it may become small. It can develop, yeah. A VSD can develop aortic incompetence, it can develop pulmonary hypertension, it can develop infective endocarditis. These are the 4 events that can happen to your VSD. So your history must reflect these 4 outcomes. Spontaneous closure, patient became symptomatic after symptoms in the infancy. He had no symptoms, he is active, running about, normal special activity, normal growth, and doctors have found that the initial murmur has disappeared. That's the history he will give you. If aortic incompetence typically is a small shunt in the beginning, not very symptomatic in early age, because VSDR occurs only in the smaller VSDs. So you must know something about the disease also. You know that the AR is progressive. The shunt becomes smaller, but the AR is progressive. Starts increasing towards the end of the first decade, and in the second decade or early third decade, starts producing heart failure. He'll start complaining of symptoms of heart failure, increased precordial activity, prominent carotid pulsations, and so on, palpitations, so on. And of course, an uncorrected large VSD would have symptoms in infancy, and then he would become asymptomatic. His history would reflect no symptoms, but you must be careful. No symptoms could be closure, could also be PAH. So you ask questions whether he has limited effort tolerance, whether he gets pre-syncope on exertion, whether he feels atypical chest pain due to RV strain, whether he feels pulsations due to RV heat. Now, those are the questions you target and ask about particular illness. Next slide, please. Now, 11-year-old girl chest pain. Chest pain, there are numerous causes, but this one has localized pain in the left parasternal region. Where pointedly, she gives one finger point to the fourth left intercostal space. Fourth intercostal space, close to the sternum. That's the region of the costochondral junction. It's intermittent, lasts only for a few seconds. At rest, as well as on exertion, has not affected her effort tolerance. Occurs intermittently, and local tenderness is present. Now, this is a very, very typical history. You can't confuse this with any other pain. You can't confuse with cardiac ischemia. Cardiac ischemia doesn't last for a few seconds. It doesn't come and go, come and go. It has been going on for several months with no change in their health. You can't have cardiac ischemia going on for several months. And local tenderness doesn't occur in any cardiac pain. It has a local chest wall pain. So you can straight away say that this child has probably a normal heart on examination, and due to probably be some cause in the musculoskeletal system, maybe costochondritis, maybe muscle tenderness, maybe a strain of muscle strain after exertion. So whenever you, next slide please. So whenever you are evaluating a history of a complaint, you have to keep all the causes in mind, common causes and rare causes. But you don't have to consider all the causes in everybody. For example, this pain I just described would probably fit in one of the first, second. It could be musculoskeletal pain, it could be post-traumatic pain, it could be costochondritis, it could even be anxiety and neurosis pain over the heart. Now, if you have respiratory pain, pain in the chest due to respiratory, you may have classical pleural type of pain. Like when you take a deep breath, you get pain. When you cough, you get pain. When you hold your chest and reduce the chest movement, the pain is the pain. Herpes zoster, all of you know, confined to one segment, one neural segment, intercostal space. Pericarditis, postural pain. If you lean forward, it improves. When you lie down, it may have, but it may change with posture and so on and so forth. So every cause has a typical pattern. I don't say that in every case you'll be able to make out the differences, but you should try and make it out. Now, so the questioning in history and presentation should be directed to the probable cause that you have made. Next slide, please. Now, A chest pain is important. Everybody is worried when somebody has chest pain. Even if a child has chest pain, mother is very worried. The doctor is also worried. The pediatrician is worried. Now, whenever you have chest pain, there are always some red flags which you would stop. Now, a chest pain in a person who has previous existing heart disease is different from a chest pain occurring in a person who doesn't have history of heart disease. If it's effort-related chest pain, it's likely to be myocardial ischemia, likely to be aortic stenosis or hypertrophic cardiomyopathy. Okay, so a central chest pain is more important than a peripheral chest pain. A central chest pain is more likely related to the mediastinum, and mediastinum includes the heart, whereas a peripheral pain is more likely to be non-cardiac pain. It could be respiratory, it could be intercostal muscle, it could be pleural. Now, infants do not complain of chest pain, but what you should ask is, does the child is able to finish her feed? If the child becomes restless and sweating on during the feed. Now, sweating is an associated symptom. That's very important. Associated symptoms are very important in evaluating the primary complaint. If difficulty in breathing is by itself may not be that important. A difficulty in breathing, if sweating and giddiness becomes more important. Failure to thrive. Now, there are hundreds of causes of failure to thrive. Failure to thrive with underlying heart disease, with features of heart failure. You should try to evaluate these three parts of the problem on history. And finally, if the family has heart disease, you have to be more careful before dismissing it as an insignificant complaint. And therefore, that's very important because everybody is anxious, and some diseases can run in the family. Next slide, please. Now, if a girl is fainting episode, it could be cardiac, it could be neurological, it could be vascular, it could be anything. It could be an embolic episode and a stroke, it could be epilepsy, it could be, you don't know. Now, so you have to go through a number of questions, and I'm not going into the details of the question. If somebody has been having chest, yes, cardiac symptoms and frequent episodes of fainting, you must redo a cardiac workup as well as a neuro workup, which could be either of the two. Of course, you take a history for circumstances, precipitating factors, relieving factors. Now, if the patient exerted and then felt fainting, it's very important sign of cardiac disease. If there are precipitating factor, lifted some height, did some was a prolonged standing, he saw some unpleasant sight, somebody getting injured, he saw the bleeding wound of a person.
Yeah.
Or, yeah, a duration of it. Now, somebody faints and says, I was unconscious for 2 hours. You know that it's not a cardiac syncope. Cardiac syncope. I'm sorry. I'm sorry. Yeah, go back. Now, a cardiac syncope is transient loss of consciousness due to failure of cardiac blood supply to the brain. Now, it can't last for more than a few minutes. If more than that, it leads to it's a cardiac arrest situation. So, anything if the patient says he remained unconscious for 2 hours after the event, it's definitely not cardiac syncope. So, duration is important. Each episode you have to describe. The patient says, I was sleeping and I woke up with a shout, and then I had parents say the child woke up with a shout, and then I found the child unconscious. Extremely unlikely that it's a cardiac syncope. Cardiac syncope doesn't occur during sleep. It's an event. It could be an arrhythmia, it could be asystole, it could be complete heart block, or it could be vasovagal. All of it generally occurs when the patient is active, and more commonly when the patient in the erect posture, because gravity tends to get blood. Something which happens in sleep, very unlikely to be a cardiac syncope. Now, the associated symptom in favor of cardiac disease over. If they have convulsions right at the beginning and followed by a prolonged period of drowsiness, most likely to be a epileptic seizure with a post-episode drowsiness. And therefore, that's how you go through the history. But sometimes you may have to proceed to investigation, but it's a good starting point to ask questions from history. Next slide. And now all these conditions can cause fainting. Vasovagal fainting, typically the patient is healthy and active. She has been having these episodes for many years, like from 2-3 years of age. But now she's 12 years, but 10 years of syncope and nothing has ever happened to her. She has always remained well. She never hurt herself. She doesn't have any breathing difficulty. They never developed heart failure. Now, this long history of benign fainting, typically occurring in standing position at school prayer meeting, after seeing some unpleasant sight, after a injection given in the sitting posture, and it is transient. The moment she hits the horizontal position in the ground, she feels better. Very suggestive of weather. Severe aortic stenosis, the only complaint may be syncope, but it requires exertion, running up the stairs, carrying some weight. Pulmonary hypertension, syncope may be the first clue in idiopathic pulmonary hypertension because nobody has ever examined the child or even an adult. Therefore, you should have symptoms of exertional dyspnea, which they never notice because it has been gradually developing. But when you ask, they remember, yes, earlier I used to play badminton, but now I'm not able to play it for the last 1 year. Cardiac arrhythmia, usually palpitation. It could be either tachyarrhythmia or bradyarrhythmia, but both can cause palpitation, prominent heartbeat. And very rarely to have a serious arrhythmia during sleep, symptomatic serious arrhythmia, because invariably the arrhythmia causes hypotension, and this hypotension is aggravated in the upright posture. The patient is supine. Many arrhythmia do not cause enough hypotension to cause syncope or even seizures. The arrhythmia may come and go unless it is ventricular fibrillation. Hysterical faint, they may faint and remain unconscious for 3 hours, 4 hours. Now those are typical hysterical faints. And of course, seizures, there are various forms: active motor seizures, absence, and falls with loss of motor tone, and so on. So you should be a good general physician also to evaluate episodes of fainting. Next slide, please. So from all this, you must realize that you need different skills for getting a good history. You have to have a background knowledge of the possible causes which cause these symptoms in this patient of this age group in this background. You should also know all the causes, and you should also know which of those causes, maybe one, maybe two, maybe three, which fit the history of this patient. Therefore, background knowledge of the disease is very important. Background knowledge of the subject is very important before you can be a good historian. Now, all of you read your textbook, but it is important to remember the critical point and apply them at the bedside. You should be very skilled at collecting information from the patient. The way you ask question makes a huge difference. The way you set the patient in relaxed mood and you get and elicit his cooperation. Finally, you should have a very, very intelligent analysis, make some convincing conclusion, and make a convincing presentation so that the examiner or your consultant is convinced and agrees to proceed on that line of investigation. Or when you are a consultant, you have to do this for your own good. Next slide, please. Next. So I'm coming to the last part of my talk, and I'm not closing it. I remain open for questions. Now, the title of the talk said it's the art of clinical history taking. Now, is it an art or is it a clinical method? You could call it an art, you could call it a method. A method or a technique is a repetitive procedure. Therefore, if you keep on doing it, it will improve with practice. It's a mechanical position. There's nothing creative in a technique. If you learn a technique, you keep on doing it, you become good at it, but nothing creative about it. So I don't think history taking is a pure technique. It has a large element of art. Art means it is creative. Next slide. Next point, please. Next point, please. Yeah. Art can also improve practice, but you need some innovative thinking. You all keep on allowing for every question, you have to think, what is this patient telling me, and what is the next question I'm going to ask. So you have to improve practice, no doubt, but it requires innovative thinking, a little bit of imagination. Something which happened 10 years ago, something which happened 5 years ago, and something is happening now. You need to be able to link them together, intelligently link them together. Some out-of-box thinking, some detective work, and you have to build a very interesting. Interesting doesn't mean just a story. It has to be accurate to the less possible. And finally, the statement I would make is there's absolutely no perfect way of history taking. It cannot be taught to you by anybody. I cannot teach you this. I can only tell you what I observed in my years of practice and what tips I found it useful. So it's up to you to do it again and again, do it in front of other people, so that you become confident with presentation, you become confident at building a story at presentation confidently, and develop your own unique way with repeated practice. Repeated practice is very important. You need a lot of background information. It goes into it, although everybody thinks history taking is very simple. And the the analysis and the final conclusion is what it makes it your unique way, and impress the patient as well as make it useful to the patient. Next slide, please. I think I'll stop here and thank you for your attention, but I'm willing to take questions. Thank you.
Thank you, sir. Thank you. Very nice presentation, Miss. History taking cannot be better taught than what sir says. And I request the panelists, Dr. S.N. Singh and Dr. Saad, to come and put your point.
Yeah.
Thank you, ma'am.
Thank you,
Okay,
sir. for
sir,
very-
you go ahead.
Yeah.
So this is indeed so. Professor Raghavan sir is the teacher's of our teacher. So this was like expected from him, and this is really the great beginning of the session on cardiology, in which sir has talked about the art of the speech, which is really a lost art. And definitely all the participants, and especially the postgraduates, must have benefited from his talk. And what I want to bring one point, which sir has also, what his presentation has shown one very beautiful slide in which how to communicate with the child, and that picture depicts all the things which has been there. There should not be any communication gap. There should not be any barrier to it. And what one point what I want to bring, that most of the postgraduates, especially while presenting their cases, quotes their points in verbatim. What happens so they just start their history that the patient has gone to one hospital, taken their treatment there, and there's some treatment started there, and then some other hospital, then there. But because of all our MBBS teachings, we have been told that we have to repeat what has been told by the patient. So some points on that, sir, if you can elaborate, that they should be specific enough on that.
Yes. See, when that's a very important point that you have brought up, sir. Thank you. Now, it's always said that a patient's own language and it should be communicated in their own language. That's true for the initial, when you enumerate the symptom, you should say, you don't say that he has class 4 dyspnea. You should say that I have breathlessness on running up the stairs. I have breathlessness on carrying my school bag to school. That's the way the patient tells you, isn't it? So you say, my 4-year-old boy patient has breathlessness when he goes to school carrying a school bag. That's the way you say that. Now, because you're telling in third person. Now, but when you start discussing the present illness, you don't stick to the patient's own language, because you have to, at that point, you should move from the patient's recitation to more scientific. You're converting that data of the which came in input from the patient, you're converting into data which now you can analyze by scientific terms. That's what it is. So you have to convert that point into scientific language. You have to say that he had breathlessness on mild exertion initially on carrying a school bag, but later on it increased to class 3, that he started getting breathless even on routine home activities. That's the way you convert it into. Both these are important. Now, sometimes the patient, they give you a lot of information which may not make sense. You don't dismiss it. Don't tell them this rubbish. Don't tell me this. Never. Listen to everything. If you want, even scribble it down on your paper at the top. How much importance to give to that statement, you decide at the end of your history taking. Some of them you just trash it. Some of them you will use it. So do not use verbatim statement. As I said, no, he will say, I ate watermelon and had chest pain the next day and developed this, and you say he has got pericarditis. Now, watermelon doesn't cause pericarditis, but patient is convinced that he ate watermelon and he got this heart disease. That sort of statement you should filter out. You can't use verbatim those statements. So when you convert this into scientific statement, you can start interpreting it after that. And grading the symptom is very, very important. I bet you ask anybody who has chest pain. Yes. Have you had chest pain? Yes, I have. Can you get one person who says he has never had chest pain? Everybody has chest pain. He has muscular pain. He ran in the school and fell down. He had pain, hit himself in the precordium. Everybody has transient chest pain, transient flatulence, and gastric distension also causes lower abdominal chest pain. But you have to ask this pain, central retrosternal occurs on exertion. Does it associated with sweating? Does it occur with palpitation and breathlessness? Does it get relieved by rest? And have you been reducing your activity due to this? So you have to ask specific questions and make. Is it localized? A true cardiac pain is never localized. It doesn't occur in the left precordium. It occurs in the central because the sympathetic pain, the heart doesn't have dermal nerves. It has autonomic nerves. All the pain or symptoms of the heart is related to the midline. You get my point? So it has to be his story has to be converted to a language which the scientists understand. Thank you. Next question.
I think Essence Singh, sir, you want to ask something?
Yeah. So, no question, but thank you, sir, for a very nice presentation and highlighting the very important aspects of history taking, sir.
Thank you, sir.
So, thank you, sir. As there is no more question, but all the delegates are very carefully listening, full-time attendance. That is the best part we have achieved. And this is student focus. So obviously they are just listening to the beautiful talk, and it will be recorded and will be shared with all the registered delegates. So it's we need to listen to this talk repeatedly. So we have to learn each and every sentence which sir has said. So remembering that, interpreting that smartly, using with your history when you are assessing the patients. So that is the smartness we have to apply to the whatever we are getting from our seniors or our textbooks. So smartly using everything, patient history and the sir talks, every have thing to be used smartly. So thank you, sir. And it is, yeah.
Good morning, ma'am. I'm Dr. Vikas from Aligarh. May I have a very small question from the respected sir, because we have got the opportunity to interact with him. So may I ask a very small question, sir?
Yeah, sir.
Sure.
Go ahead, sir.
Namaskar, sir. I am
Namaskar.
Vikas Malhotra from Aligarh. Sir, there's a very, very pertinent, it might not be relevant for today's topic, but 14, 15-year boys, they are coming, and post-COVID and post, news are pouring in the media of the sudden deaths. Parents are just any chest pain, and they are relating to cardiac. So I think just if you just spend 1 or 2 minutes on this topic, this will be very, very helpful for practitioners. Basically, everybody is concerned कि सर chest pain हो रहा है, मेरे बच्चे को chest pain हो रहा है, and all sorts of rumors are. So how to proceed with this by history taking and some basic clinical examination? Thank you, sir.
Absolutely. And chest pain is very much in the news. Everybody is reading of sudden death and how young people are getting heart attack and all those things. People have become aware. The media is also talking a lot about it. And one young parents are very worried about the kids and their sort of, whereas one kid or two kids, and they are so worried about small complaint. And COVID has made things very, very difficult for everybody. And yes, you're right. Young patients are getting post-vaccination carditis and thrombotic events. But of course, as doctors, we know that everything in medicine has a negative effect. So it's always a question of balancing the positive effect and the negative effect. If the positive effect overshadows the negative effect, it's probably useful in the wider number of society, although the individual patient may be harmed. So the incidence, the benefits from COVID vaccine far outweighs the damage caused by thrombosis in a few patients. Numerically, the number of lives saved by COVID vaccination is far, far, far greater than the number who got thrombosis and or myocarditis and died. Therefore, I mean, that is one part of the story. But that doesn't help the patient because he's worried about his child. I gave vaccine and now he's having chest pain. And chest pain is one of the most common complaint now in child. Believe me or not, I'm sitting in an OPD and young parents coming with their 3 to 12 years, and particularly the middle and high school children. The exams comes near, everybody has chest pain, and they are also tense. Their life is also becoming busy and tough. Therefore, you have to look at the clue. You have to look at the background. And they've been well, they're still active, but they've been having a long history of high performer, exams approaching, very atypical chest pain, like the girl I described in the slide. No transient pain localized to left precordium, unrelated to effort, local tenderness, and when you're examining, you're watching for signs of anxiety. The girl is you can make out anxiety on their face, you can make out anxiety on the face of the mother, and that compounds the pain in the child. Therefore, it's an overall evaluation supplemented by physical examination, of course. If you have a history which is very atypical for any organic pain, so I told you the clues to organic pain. Previous history of heart disease, family history of heart disease, the severe symptoms associated with symptoms like sweating, breathlessness, or syncope, having abnormal signs on examination, and so on. There are some red flags to every symptom, and one of them is chest pain. You have to look for every sign. Of course, nowadays ECG is considered a basic ECG test in cardiology. You have a normal ECG, normal history, normal physical examination. I don't think you need to proceed with any further than that, and you have to. Now, one of the things I would say is everybody asks for an echo in chest pain. Echo is the last investigation should do. It's not necessary, but echo doesn't give any information about chest pain. Now, a good history and physical examination does 90% of diagnosis, whether it's organic or not organic. And then the ECG, after the remaining 10%, the ECG will rule out significant disease in at least 5 to 8% of cases. You would be left only with 2 to 3% of cases of all chest pains in children where you still have a doubt whether it's organic or functional. Then, of course, you have to take the benefit of further investigations and all. There are conditions which can cause ischemic pain in children. Kawasaki disease, it can cause ischemic pain. Hypertrophic cardiomyopathy, it can cause chest pain in the aortic stenosis can cause anginal pain in. There are diseases, anomalous left coronary artery in an infant, chance difficulty in freezing, restlessness during feeding, sweating, heart failure. It can all cause that. There are causes, but when you are general pediatric OPD, you would find these causes all amount to less than 5%, or maybe even less than 3% of the chest pain cases. So common things are more common. That's the way it should work. But at the same time, don't dismiss the complaint. Evaluate and then decide this is not important. That is important. Don't dismiss on telephone. Never dismiss chest pain on telephone. Even if it is a child, even if it's a 4-year-old child, it's not. Please call, take a history in person. No, history on telephone is not a great idea at all, to be very frank. Yeah, you have to see the patient, you have to see the patient's body language, you have to see the patient's face, see the mother's face, and invariably you get clues to how severe the disease is, how organic the disease is, how functional the disease is. That's the way it is.
Very important point, sir. And sir, ECG is one thing, like in adult, when patient come with so-called chest pain, whether it is organic, non-organic, history-wise, we get the clue. And ECG is the first investigation being done in adult. Everybody know that ECG to be done, but in pediatric, there is one thing which is lacking. Majority of the pediatrician, they don't do because we are not obviously in pediatric time, we are not very comfortable with the ECG. So this is another very important investigation, very simple investigation, very cost effective, and we need
Yeah,
to become comfortable.
absolutely. ECG is considered practically a part of physical examination now in cardiology. I think ECG should be done in every cardiac OPD. Echo may not be necessary, but echo has no help in chest pain assessment. It has help in only in organic heart disease. And if you have ischemic pain, do echo for other things, how good the ventricular function is, and so on and so on. But for chest pain itself, echo doesn't happen. ECG is a must, I think. A very simple test. It doesn't cost much. It doesn't cost much.
Please mute yourself, Dr. Tapan, please mute the others. Now I request Dr. D.M. Gupta to come and make your comment.
Can I just make a comment? I'm telling, address the students. You are very lucky people. When we were students, nobody gave us this sort of e-lectures and e-talks and all. We had to find our way on our own. Even Manish Tomar would tell you, Dr. Manish would tell you how difficult it was. We all used to have go to the library and make notes and then know. And the lecturer, the professor will come and give a talk, but then we didn't have any slides or which they would record it and give it to us and all. You people are lucky. You're living in a new era. You're sitting at home and you're watching these talks and getting so your consultants and teachers are working hard to give you this material. So you should be thankful to Dr. the UP AOP, and I'm also grateful, and you should also be grateful to Dr. Tomar and everybody, all the association members who's making it possible. Please make the best use of it and become good doctors. That's what my wish is. Thank you.
And many senior professors are here, Dr. Mala Kumar, my teacher from KGMC. So many people are here who have joined listening to you, sir. It's really, I feel very honored that ma'am joined, many of our teachers join, and they just because I tell them that sir is coming, and so it's so important. And students obviously they're following their teacher, so that's why they are also get encouraged because madam or sir is joining, so they will definitely come
That's
and.
a, that's that's an important point you made. That is, everything is not given in the books. The real point which help at the bedside, you learn by watching your teachers. Watch how your professor is taking his tea. Watch how he is introducing himself to the patient. How he is talking to the mother, and that's what teaches you, makes you a better doctor than the person who just read the books.
Yes.
Reading the book is important, very, but these techniques you will learn at the bedside in with your teacher.
That's why we do PG like in where the patient volume is big, OPD is big, not sitting on. Otherwise, we can all study materials available online, and you can just learn whatever you need for the PG, and you can get the degree. But the practical training you can learn when you are with your teacher. So you follow them, and you just get everything from that. That we remember, Madam Professor Savitri Shrestha, her body language, everything. It's inbuilt into us. So. Thank you, sir. Thank you taking time. It is very late in US and you spare this time for all of us. Thank you. Thank you. Thank you everybody for joining and thank you UPAOP for giving us this